Welcome everybody on this webinar. Fantastic that you took the time to follow this webinar here together with me. Very exciting because we have over 550 registrations for this webinar, so that's quite a lot, I must say. And as usual, I am broadcasting here from our ETGOM GCI International Training Center here at the Belgian coast. And of course, I'm curious where you are from. So let me know in the chat if you can hear me, if you can see the image, and where are you from. So please feel free to use the chat. I'm curious. In previous webinars, we had a lot of guests from different countries. So let me know in the chat if everything is okay. First of all, can everybody hear me? Yes, apparently everything seems to be okay. Well, I received the messages in the chat here with some delay. When you type the message, then it takes about 10 seconds before I see that. But Ricardo from Brazil, welcome. Maya, Croatia, oh, it goes fast. Hungary, Argentina, Sri Lanka, India, Sophie from Belgium, fantastic. United Arab Emirates, Bulgaria, Jeroen. Wow, that's crazy, fantastic. Okay. And it goes on: Switzerland, Kosovo, Brazil, Bahrain, Malaysia. Oh, great. Okay. So, other people from Bulgaria, from the UK, from Poland, from Bangladesh. Really fantastic. Well, what if you could have efficient tools to examine your shoulder patient? And remember, when you registered for this webinar, I asked you a question: what is, according to you, the most difficult shoulder lesion to treat? And yeah, you gave me a lot of answers. And if I just look at my notes, what do I see? Very frequently, most of you seem to have problems with the treatment of a frozen shoulder. In second place, there seems to be problems with bursitis. And there are also quite some problems with rotator cuff lesions. Well, then I have good news for you today, because I'm going to talk a little bit about the differential diagnostic options, for instance, tendons, bursitis, arthritis, and so on. In the meantime, well, once in a while, I'm going to have one eye on the chat over here, and I see that we also have guests from Cambridge, also from Antwerp in Belgium, and from Iraq, from Canada. That's really fantastic. But one of the things that one of your colleagues wrote down in the questionnaire, he said, I'm going to quote, "Great to know about this webinar. I am obliged you are providing valuable knowledge for free of costs." Isn't that fantastic? Actually, yes, this is my purpose. I would like to inspire you. I would like to motivate you. I would like to give you some tools which perhaps you can use in daily practice in order to have more diagnostic success and more therapeutic success. But let's be honest. Let's call a cat a cat. Of course, when you are interested in musculoskeletal medicine, when you feel that you can do something with those tools I'm going to share with you, and when you say, okay, I would like to find out more about that, and you would like to register for one of our courses somewhere worldwide, or you would like to register for the Mastermind private training, well, of course, me and my team, we appreciate that very much. That's logical. Or you would like to sign in or the online ultimate toolbox. Well, that's also fantastic, of course. We also appreciate that. Well, at the end of this webinar, I'm going to present to you our new online ultimate toolbox. And especially for you, only for you who registered for this webinar, I'm going to make you a special offer at the end of my story. And for those of you who are live at this moment, who are following this webinar now, I also promised in the announcement of the webinar there would be some extra surprise for you. Well, you're going to see that also at the end of the webinar. Okay, I have a promise. My promise today for you, at the end of this webinar, you will be able to examine the shoulders in a pretty easy and logical way. But not only examining the shoulder, but you're also going to understand what you're doing. Because we can do a lot of techniques, but of course it is important to know what exactly we are doing and what is the purpose, so that you have more success in clinical reasoning, that you have more success in diagnosis. And I have to be honest, this is a little bit, I would call it my core business, but I'm a big fan of clinical reasoning. For those of you who are here for the first time, well, let me briefly present myself to you. This picture has been taken about 40 years ago. Can you imagine? And what you see on this picture, well, this picture has been taken in the clinic of my father. My father was also a physical therapist. And the man you see over there on the table, the patient, well, he's my father. And the man on the right side, he's Cyriax, Dr. James Cyriax, watching a colleague from Holland doing his exam in orthopedic medicine. And the yellow guy you see over there, well, believe it or not, but that's me. So I grew up in an atmosphere of orthopedic medicine. I saw my father working in a specific way, doing specific things. And I said, okay, later when I grow up, I would like to be a physical therapist, but I would like to also evaluate into this orthopedic medicine direction. And as you can see on this picture, also Cyriax watching while a colleague is doing a loose body manipulation in the hip. And the other picture, you can see me in the middle over there, but I don't expect you to recognize me because my physical appearance at that time was apparently a little bit different, but I was doing the dishes together with the wife of Cyriax and another lady. So that's briefly my background. And in the meantime, I had the pleasure to publish a lot of books and handouts and hundreds of film productions. But talking about film productions, well, at the end of the webinar, I will tell you a little bit more about that. And of course, this resulted in the creation of our ETGOM GCI International Teaching Team. Small, beautiful team, but with this team, we cover courses really worldwide. We were already a guest in about 40 countries. So that's a little bit to give you an idea about our background. Help. Sometimes I feel like an idiot. That's strange, huh? Imagine spine. I'm already working now in private practice. Let me calculate. Almost 33 years. And of course, like you, I'm convinced we all did already many different continuing education courses. And sometimes I feel like an idiot. And you know why? I see colleagues doing all kind of examination procedures, all kind of techniques. And specifically in the spine, I see people who seem to have phenomenal manual talents and who are able to feel some kind of hypomobility between L3 and L4, and there also seems to be a problem in left rotation, and so on and so on. And they really seem to have a lot of manual skills. And the problem is, when I go home and I try this at home, I don't feel that. I feel like an idiot. Is there somebody in the group who also sometimes has this feeling? Let it know in the chat. If sometimes you're also confused, you're a little bit disappointed. The teacher in the course is showing this and this and that, but when you're honest with yourself, you don't feel it. Yeah. And then mostly people say, yeah, but you need at least 15 years of experience before you really can have the fingers. Yeah. In the meantime, I see that some of you share the same feeling with me. Okay, I have good news for you. Even today, sometimes I feel like an idiot, but the good news is, Jeroen, you also feel that. Oh, fantastic. But the good news is, don't worry. This is completely normal. If you need 10 years of experience before you can feel something, then that simply means that this kind of procedure, that this kind of act, that this is not pretty relevant. In my opinion, if you don't feel it in the first minutes, so to speak, you're never going to feel it. So the good news is, relax. Even in 2003, when I had the pleasure to publish some books in the United States, in this book, on the first page, I wrote a quote: "Flying above the clouds where the sun is always shining is nice, but flying without knowing how to run makes the landing very painful." And I still strongly stand behind this quote. There's nothing wrong with flying high in the sky where the sun is always shining. There's nothing wrong with that. But if we don't manage our basics, then we're going to stumble. And this is something I see a lot during live courses we teach worldwide, that many people do all sorts of different things. There are also some fashion waves in musculoskeletal medicine, but we forget the basis. And this is exactly what I would like to share with you today. Today, we're going to talk about the basic principles in musculoskeletal medicine. And wouldn't it be nice if you could help your patient even better? Yeah. Let's be honest. It's helping your patient in a more efficient way. That's nice. But it also gives for yourself and for ourselves as therapists, we also like to have some professional satisfaction. And this is in fact the main reason why I love to do these webinars, why I love to share this information with you. Eduardo, in the meantime, said something interesting in the chat, so let's have a look. I suggest you have a look at this reference. I have a challenge for you today. And for this challenge, I created something special just for you for today. If you look at the right side of your screen, you should see that a PDF file or a link to a PDF file is appearing. Yeah? So let me know in the chat if it is appearing, if the technology over here works fine. You have there a PDF file, the shoulder checklist. Download it now. And at the end of this webinar, or tomorrow, or in 2 days, have a look at this checklist. This checklist is a challenge, is a personal challenge for you. What are you going to find in this checklist? You're going to find 8 different questions. And the challenge is that you take 15 minutes of time, focused, not disturbed by any family members, not disturbed by the children, not disturbed by the dogs, whatever. 15 minutes of focus. And you take those 15 minutes to write down an answer on those 8 questions. And then you analyze for yourself, where am I in my clinical reasoning procedure? Okay, but we're not going to do that now, but I give that for you as an extra tool to use later. Okay? Good. So I leave the file open there so that you still have some time to download it. Okay. The first thing we do when we see a shoulder patient, of course, we have to focus on the history and on the inspection of the patient. But one little detail: we are the professionals, okay, and the patient is the patient. But sometimes we ask questions to the patient that the patient doesn't understand. We understand it, we know what we're talking about, but this is not always so clear for the patient. So make sure that at all times the patient understands what you're asking. And sometimes ask the same question several times in a different way to make sure the patient understood you very well and that you understood the patient. Okay? And also in my history taking, I'm also going to ask the patient, tell me, what do you expect from me? What do you expect that I can do for you? What do you expect is going to be the outcome of your visit today with me? Yeah. So make sure that we understand each other very well. And of course, when a patient is complaining about, oh, my shoulder hurts, yeah, where is it coming from? Of course, you have several options. Huh? You cannot exclude mechanism of central sensitization. Certainly not with spine patients and shoulder patients. That happens. Certainly in those 2 groups of patients, that's not rare. Of course, most of the patients who say, "Oh, I have shoulder pain," don't have a shoulder problem. And you know why? Because in case of shoulder problems, mostly there is referred pain. And there are some rules regarding referred pain. More about that in other online courses, in the online ultimate toolbox. But the shoulder mostly is going to refer pain somewhere in the C5 dermatome. So most shoulder patients, they have pain somewhere in the C5 dermatome, and this is the C4 dermatome. So then you first think of acromioclavicular problem, lung problem, cervical problem. So you have to understand the mechanism of referred pain. I also would like to know if there is a local problem in the shoulder, which kind of problem? Is it a contractile problem or is it an inert problem? And what's the difference between the 2? Well, contractile, muscle belly, musculotendinous junction, the tendon, insertion. What is an inert lesion? That's all the rest. Yeah, capsule, ligament, bursa, this kind of structures. But also don't underestimate psychosocial factors. I was also happy to read in the questionnaire when you registered for the webinar. Eduardo wrote down or mentioned, and I'm going to quote Eduardo, "In my opinion, the major problem in the shoulder is not the lesion itself, but the patient's complexity. The more psychosocial factors involved, the more complex the patient will be, and consequently, the prognosis will be worse. Patients with good self-efficacy have a great chance of recovering regardless of the injury." Thank you very much, Eduardo, for this quote, because that goes perfectly together with the slide over here. People who believe they're going to get better, they get better. People who don't, they have an extra problem. Okay, so keep that in mind. But there are, of course, in the history of the patient, some important basic questions. Chinmoy, I hope I pronounce your name correctly. You are asking, what about frozen shoulder? Well, if you give me a few more minutes, I'm going to make a link in that direction. Is that okay for you? So where the patient says my shoulder hurts, where? Yeah, what did I tell you 2 minutes earlier? Is it in the C4 dermatome, or is it in the C5 dermatome, or somewhere else? Was there any trauma? If there is a trauma, and for instance, you find the image of an arthritis, then, okay, we combine the two, then you have a traumatic arthritis. Yeah, great. That's interesting, because there are different types of arthritis. There are different kinds of arthritis. And a traumatic arthritis is going to be, let's say, a good responder to physical therapy or to physiotherapy. Some other types of arthritis are not. So that's why we keep that in mind. But the major question in the history, you ask to the patient, okay, since you have this problem, which activities of daily life disturb you? What makes it worse? What makes it better? And you have to ask that question several times, because the patient is not going to sit there in front of you with a list and say, what makes it worse? No, he's going to think of a few things, but then we have to dig a little bit further. I have to analyze his activities of daily life. But very important, when the patient gives you a big story, I can't do this anymore, I can't do that anymore, oh, problematic. And you find a small clinical image, you don't find many positive tests. So there is a contrast between the story and the functional image. Don't underestimate the, let's say, psychosomatic or psychosocial context, okay? With normal musculoskeletal lesions, a big image always goes together with a big story. A small story goes together with a small image, okay? Tell me, since when do you have this problem? Yeah, I not only want to know if it is acute, if it is chronic, subacute, whatever, but some pathologies, they have a kind of spontaneous evolution, and that's also interesting to know. For instance, this traumatic arthritis, hypothetically, you don't give any treatment whatsoever. Well, in about 8 to 12 months, this patient is going to recuperate completely, no problem. But you're going to have 3 different phases. Phases where the pain and the limitation increases, where it stays stable, when it gets better again. And depending in which phase we are, the treatment could be different. Or, as you can see on the screen, an acute bursitis. A real acute subdeltoid bursitis, that takes 6 weeks. In 6 weeks, that's okay, without treatment. But the patient is going to appreciate treatment, because the first 3 weeks are really hell. Do you have problems in other joints? Yeah, of course. You make a link with other system diseases, with, for instance, rheumatoid diseases, with inflammatory bowel disease. Those patients can also have intermittent problems somewhere in the extremities. So keep that in mind. Yeah. Okay. So if in the meantime you have some question or something, just put it in the chat. Once in a while, I'm going to have a look over there. Okay? But we have 3 more questions which are so interesting to determine the stage of an arthritis. And we had a question about the frozen shoulder. Well, a frozen shoulder is one of the kinds of arthritis. And the 3 questions are those you see over there. Do you have radiation of pain that goes further than the elbow? Can you lie on that side? And do you have pain at rest? And what do we do with those 3 questions? If you have 3 times a favorable answer, I don't have radiation that goes that far. I don't have pain at rest. I can lie on that side. And you find the image of an arthritis, then we're going to call this arthritis a stage 1. So that's, in other words, that's slightly irritated. If you get 3 unfavorable answers, a lot of radiation, constant pain, I can't lie on it, then it's pretty much irritated. It's stage 3. And why is that important? Well, the treatment of a stage 1 is completely different than the treatment of a stage 3. Not a little bit different, completely different. Some other things which we can keep in mind when we focus on the history, what I already told you, okay, I would like to know what the patient is expecting from me. I must make sure I'm clear to my patient, that he understands me and that I understand the patient. And I certainly want to give the patient some confidence. Yeah? Some patients come to us with a very, very negative mindset. Certainly in the spine, yeah, the best example in the spine, and I'm sure you all know that. The patient comes to you and says, I have 3 hernias, you know. I have 3 hernias in my spine already during 5 years. Oh, terrible, yeah. Yeah, this patient is in a very negative track. We have to give this patient some confidence. We have to reassure the patient. We have to, in most of the cases, nothing is broken in the shoulder. Yeah? No, it's just a temporary functional problem, and we have to make the patient aware of that. Okay. Okay. That was a brief introduction to the history. What about the functional examination? Well, I'm going to divide it in 2 parts. First, I'm going to share with you the basis of the basis. And I'm sure for many of you, the tests I'm going to show now, you're going to be familiar with that. But nevertheless, I'm convinced that you will pick some little details left and right, because as I said before, it's not just about doing the test, it's more about realizing, what am I doing and what is the purpose? And the technical aspect is something we may not underestimate. So first, the basic. Then we're going to talk about some, let's say, accessory test or accessory orthopedic test, and I'm going to explain you how you can interpret that. Okay? So the basic tests, when we do passive tests, the passive tests are mainly tests for the inert structures, and the resisted test, maximal, isometrical, are mainly tests for the contractile structures. But what are we testing? When you ask the patient to do an active test, then you would like to know what happens with the pain. More, less, the same. And what happens with the range of motion? Okay, not enough. When you do passive tests, I would like to have information about the pain, range of motion, and the end feel. Yeah. When you do resisted tests, we have to take into account the variable pain and weakness. Always keep that in mind. But to make things easy for you, I developed a tool, a standardized assessment form, which you can use in your daily practice. And at the end of the webinar, I'm going to give you a PDF of the assessment form. So make sure that you remind me about that, because I'm thinking of so many things at the same time. So if I would forget that at the end of the webinar, let me know in the chat that I give you the PDF, okay? Before we test, what do you feel now? Okay. Active bilateral elevation. This is not a shoulder test. Yeah, this is a little bit of everything. Yeah, you have scapular movement, you have glenohumeral movement, but one of the things, I'm not going to go too much in detail during this webinar because we have 1 hour 15 minutes together. But make sure you don't miss a painful arc. More about the painful arc later. We do the same test in a passive way. Go to the end of the movement, slightly provoke, and in normal circumstances, you expect to have an elastic end feel. But okay, make sure you don't miss a painful arc. A painful arc in the shoulder is something that, oh, I love it. I love it enormously. Actually, there are about 6 ways to interpret a painful arc. If you find a painful arc in a functional examination, that could have 6 different reasons. The next test is the glenohumeral abduction. So we're going to check the 90 degrees of glenohumeral abduction, and we're going to block the lower angle of the scapula. So we don't have scapular movement anymore. So in normal circumstances, when you do the first test, you have about 60 degrees of scapular rotation. So now I don't want this. We're going to exclude that. Then we go to the passive lateral rotation, and here I notice during live courses that many people make, let's say, a little mistake. Make sure that the patient cannot compensate. So that's why that you see that Maurizio, our Italian teacher, one of our Italian teachers, is holding, is giving some counter pressure at the other shoulder. But make sure you go to the end of the movement. And the end mostly lies further than you suspect. When you go to medial rotation, also go to the end. But I'm not interested in retropulsion. I'm just interested in medial rotation. But something strange could happen during the medial rotation. Start doing the movement, and at a certain moment, the patient says, ow. What's the first thing you do? You ask where. And then the patient says, somewhere over here. Yeah? But continue your movement. Don't stop too soon. Continue. And in many cases, you're going to find a painful arc on medial rotation. And a painful arc on medial rotation very often goes together with a chronic subdeltoid bursitis. That's not the only test in a bursitis, but very often you see that. So keep that in mind. Yeah. After those passive tests, we can already discover a certain pattern. We talk about in orthopedic medicine, we talk about a capsular pattern or a non-capsular pattern, but the capsular pattern in the shoulder is in fact a limitation of movement in 3 different directions. But lateral rotation is most limited, then abduction, and then medial rotation. It could be a small limitation, could be a big limitation. The proportion between the movements is important. If you find this pattern, this points in the direction of arthrosis, arthritis. And when are we talking about arthrosis? When you find this pattern and the end feel on different movements is harder. When do you talk about arthritis? The end feel on those movements is muscle spasm, is really quite painful. In this way, we come to the conclusion of arthrosis arthritis. And remember what I said a little bit earlier? The 3 stages of the arthritis: slightly irritated or heavily irritated. Okay. We continue with resisted test, maximal isometrical. Resisted abduction. Okay. We test supraspinatus, but not only supraspinatus. Abduction, you test pectoralis, latissimus, and friends. Lateral rotation, you test infraspinatus, teres minor. But keep in mind, we have, I told you earlier, we have 2 variables. What happens with the pain? What happens with weakness? And for instance, weakness on resisted abduction or weakness on resisted lateral rotation. Yeah, on the slide you see there could be a problem with the C5 nerve root, but also in our course we discuss at least 5 or 6 different clinical reasons why there could be weakness on the resisted test. And this is, of course, everything is part of the clinical reasoning process. And then the resisted medial rotation, you're talking about subscapularis. Don't worry, I give you quite a lot of information now, but as promised, you're going to receive an email. After this webinar, you're going to receive an email with a link to the replay version of this webinar, and this link is valid for 3 days, if I'm not mistaken. So if you can watch it again, relax, no problem, you receive the link, okay? But there is something which is very important. Resisted abduction, are you only testing supraspinatus? Resisted lateral rotation, are you only testing infraspinatus? Is it such a specific test? The answer is no. You may not forget that the insertion of supra, infra, teres minor, actually they are, let's say, interconnected anatomically. So that's logical that abduction is not just a test for supra. The supraspinatus is anatomically super connected with the subdeltoid bursa. So the one can influence the other. So keep that in mind. And the bottom line of the story is going to be, we always have to look at the clusters of tests. One single positive test never has any meaning. Yeah? Look at a cluster of positive tests, a cluster of negative tests. And in the meantime, I see that Alessandro from Italy joined. Welcome, Alessandro. And we have some more resisted tests, resisted flexion and resisted extension. So that's about the basic examination in the shoulder. As one accessory test, we can do passive horizontal abduction. And this is a test which is positive in the case of an acromioclavicular joint problem or a subcoracoid bursitis problem or a subscapularis tendinosis. That's also an option. Okay. My advice is make sure we perform the tests in a good way, make sure we respect the grips, and that you really go end range, okay? So to make life easy, we have a standardized assessment protocol, standardized assessment forms for each joint with all the details from the history, the inspection, the basic examination, clinical reasoning, everything is on the assessment form. So I'm going to give you a copy of this assessment form at the end of the webinar, if that's okay with you. But the big advantage of an assessment form is that we don't forget anything. You have the whole procedure, you have all the details just in front of your nose, so to speak. Okay? Remember what I told you about the how irritated is the shoulder? We have the 3 questions from the history, yeah. But there's also another little detail. When you do the passive lateral rotation, if you have pain, oh yeah, I can't go any further, so pain, and then it's too much, that's pretty much irritated, yeah. If you have first limitation of movement and you try to go further and then you have pain, this is less irritated, okay. Some other things that might be helpful to determine the stage of irritation, well, as you can see on the screen, the difference between highly irritated and lowly irritated is quite clear, but actually that's more or less the same as what I told you earlier, just a few extra details with the VAS score. Yeah, but keep that in mind, okay? So, as I said before, a basic, whatever method, whatever approach, whatever way you use to come to a conclusion with shoulder patients and you feel comfortable with this approach and you're happy with it and you have results, that's perfectly fine. Yeah, I'm not talking about the holy truth today. Yeah, certainly not. The only thing I would like to do, I want just to give you, okay, a few tools which you might try in daily practice. But again, it's not the holy truth, okay? But keep in mind, if you find one positive test, doesn't mean anything. We're going to look in the direction of different clinical images. Okay, I need some fluid. Tell me, you want some more tools? And what happens in the chat? Wait and see. Of course, I have some more tools for you. Some extra tests. The so-called orthopedic test. Yeah. The messages are coming in the chat. So yes, many of you want some more tools. Great. Perhaps you're familiar with the near test or the near test, whatever. Yeah. Okay. What can we do with that? Well, I described it on the slide for you. And in the meantime, we also have guests from the Philippines. It's really worldwide webinar today. Fantastic. Just a question came in. If MTCAN test is positive, what will be the cluster test to diagnose supraspinatus? You are too fast for me. I'm going to explain that in a few minutes. Okay? So, the near test. If you provoke anterior shoulder pain, you think of something is impinged subacromial. Posterior pain, something is impinged internal. In the meantime, I'm going to hop to the chat again. To the chat, Ahmed is asking, would psychosomatic affection create false positive examination, or should I consider this irritation and how to differentiate as it makes all the tests positive? Oh, that's an interesting question. Yes, patients who have, let's say, psychosocial involvement, yes, test could be false positive. Yes. What you do with that? Well, nobody said you just have to perform the test once. So if, first of all, the image is a little bit strange because a psychosocial patient, you're going to hear in the story that something else is going on. It's not just a simple supraspinatus and a patient who says, I have problems putting my arm in the sleeve of my coat and getting something from the cupboard. You're going to hear another story. And in the clinical examination, you're going to see an image that doesn't fit. Yeah, for instance, all those test positive, or a strange combination of positive tests. Of course, I talk extensively about that in the online shoulder course modules and the live courses. But what you do is repeat your test several times on several occasions. And if there is a real just orthopedic lesion, you're going to see that the clinical image stays more or less stable. Those tests are positive, those tests are negative. When there is psychosocial involvement, you're going to see that the clinical image is upside down. Today, this is positive, tomorrow, this is positive, the day after tomorrow, something else. Repeat the test, and if you don't see, let's say, a coherent clinical image, and you also heard in your story also something that doesn't fit, then we have to think in the other direction, of course. Yeah, I hope that was an answer to your question. Yeah, here, empty can, full can, we are all familiar with the cans. But okay, how are you going to interpret it? Well, if the empty can is positive and the full can is negative, mostly you don't make a link with the rotator cuff muscles, and if the full can is positive, it's more likely to be supraspinatus. But keep in mind what I told you earlier. It's difficult just to put stress on the supraspinatus without putting stress on other structures. So just based on a positive full can, I have a supraspinatus lesion, that's not enough. Yeah, that's not enough. That could be very misleading. The Hawkins-Kennedy test, yeah. If positive, you also think of a subacromial impingement and not an internal impingement. Okay, just an idea. But I don't like the word impingement. In the online platform, I have some other lectures on impingement, but impingement, yeah. What is impinged? Supra, infra, subscapularis, biceps, acromioclavicular joint, bursa. Wouldn't it be nice to have this kind of information, that you have a more specific diagnosis, that you have more an idea, I have to look in this direction instead of this direction. And then you can also, let's say, target your treatment more as part of the treatment in this specific direction. And therefore, we need a good basic examination. This information you get from the basic examination and not from this extra test. Those extra tests are just extra. Another example is a relocation test. We have the position for the anterior instability test, but we do it with the patient lying on her back. And you provoke pain. And then with my left hand, as you can see on the picture, we push down. We do a posterior glide in the glenohumeral joint. If Timya is asking the test we just saw, do we make them just from this position as you saw them on the picture, or do we make them also when the patient is lying down, just to feel safe for the patient? Well, I also like that question. And you know why? I just told you that it is sometimes necessary to repeat the test several times. But certainly resisted tests, we're going to do the resisted test in standing and compare with the resisted test in lying. Because in standing, there is a different compression on the bursa than in lying. And if, for instance, you find that some resisted tests in standing seem to be positive, and the same resisted test in lying seems to be better or even negative, then of course you can't think of a tendon or a muscle anymore. But then you think of, haha, thanks to the contraction, there is some compression on some inert structure. And this is mostly going to be the bursa. So if you find, that's briefly said, if you find the difference between standing and lying, don't think of the tendon. Okay? Yeah. What do we do with this relocation test? We consider the test being positive if the pain diminishes during the test. So I push downward. If the pain persists, then the test is negative. So if the test is positive, then your impingement, between brackets, is not your first idea, but then there seems to be some kind of excessive anterior translation of the humeral head. Okay. Remember when I told you at the beginning, sometimes I feel frustrated. Well, this is also something where I could feel frustrated because, yeah, which objective manual test do I have to come to the conclusion that there is an excessive anterior translation in that joint? So this is an open question. I just put a question mark behind it. But honestly, I don't find that so easy. And then we have a few more tests, the OBriens test with thumb up and thumb down. Actually, the title of this webinar, Why Do Manual Therapists Use 27 Tests? That was, of course, a mimic. I could also, how do I come to the number 27? Well, I went to my library and I took one of the books on manual therapy and I just counted the test. But in other books, you find 47 tests. So everything is possible. Yeah. Okay. If OBriens test is positive, then that could be suggestive for a labral tear. Okay. Also with a question mark behind it. And then to conclude a little bit the clinical reasoning algorithm, when there is more a subacromial conflict, then you see that Jobe, Hawkins, and Neer, they seem to be positive. The glenohumeral or internal conflict, you see something else. But let me come to a message also from Joe. Joe said, I'm going to quote him again, not difficult to test, but to identify the footprint of the insertion, for instance, tenoperiosteal, of both supraspinatus and infraspinatus tendons. And here, I also have to be grateful to Joe for this question. Yeah, when you palpate supra, infra, subscapularis, yeah, you have to make sure you are on the structure. And how can you find those structures? Well, I explained that in a lot of different videos, which are also on the online toolbox, but also on our YouTube channel, Orthopedic Medicine Courses YouTube channel. You also find some videos on that topic. Okay. And another question that came from Ilyas. Is it possible to differentiate muscle tendinitis from muscle tear without medical imaging? And the question is, of course, yes. I don't care about medical imaging at first line. We all know that on medical imaging, you can find a lot of supraspinatus tears and so on. Myself, I have a partial rupture in my supraspinatus since long time. I have a shoulder problem, but it's not coming from that partial rupture. I had a very nice arthritis. Yeah, the clinical image was an arthritis. The clinical image was not the image of a partial rupture. So never focus on medical imaging first. First, focus on the findings in your clinical examination. Okay. And again, okay, the difference between a complete rupture, a partial rupture, or just tendinosis, this, of course, we see also in the other clinical reasoning courses. Good. And then another clinical reasoning option over here. Is it primary structure based or is it secondary function based? Then you can compare those two tests, the test in standing and the test in lying, and you do the relocation test as I described earlier. Okay? Yeah, it's quite a lot, huh? Quite intensive for a Saturday afternoon. Over here it's afternoon. For some of you it's morning, and for some of you it's late in the evening. Moral of the story. The cluster of best tests. There is a painful arc. There is pain on resisted lateral rotation. You have a near test, you have a Hawkins test, and you have an empty can test. If 3 out of 5 of those tests is positive, then you can think of apparently a subacromial conflict. But again, focus on your basic examination and to determine which kind of subacromial conflict it is. It could be. Okay? And never forget the basic clinical reasoning principle. Yeah? Remember at the beginning of the webinar, I said, okay, the patient has shoulder pain, but where is the pain? Is it a referred problem or is it a local problem? Is it coming from the neck or is it coming from the shoulder? You do your examination, your passive test, your resisted test, and at the end of your examination, as you're going to see in your assessment form, to which conclusion do you come? Is it a contractile problem? Or is it an inert problem? If it is an inert problem, what did you see? Capsular pattern, non-capsular pattern. Capsular pattern, arthritis, arthrosis. Do I have an idea about the structure at fault? Perhaps yes. Do I know where exactly? Perhaps no. Perhaps then I have to do selective palpation. And then I come back to the comment of Joe. Make sure you also manage your palpation techniques, that you find those structures in an optimal way. Okay? Vesna is saying, and you can read that in the chat, I agree that we should precisely know which structure is affected. 20 years ago, orthopedic physicians wrote PHS, periarthritis scapulohumeralis. 20 years ago, here in Belgium, they still write that down today. So many of them still do that, unfortunately. Okay, great. Are you ready? Are you ready to implement this in your clinical practice? What do you think? Do you think you're going to be able to, tomorrow or the day after tomorrow, to already try some of those things in your clinic? Let me know. Because after all, watching a webinar and getting some information, that's one thing. But the most important thing is, of course, what are we going to do with it? Yeah, okay. Can you implement that? Can you bring that into your daily practice? Let's hope. About treatments, I'm not going to talk today, or not too much. I already mentioned some things, yeah. But keep in mind, whatever you do with the patient, explain to the patient what you plan to do, what the patient expects, but not only what we can do, but never forget, certainly with shoulder problems, never forget, here's also what you can do. Our part is, let's say, limited. We can do a number of treatment techniques, specific treatment techniques, less specific treatment techniques, exercise therapy, a lot of interesting things we can do, but never forget what the patient also can do. And that's, of course, the most difficult part. Yeah, that's logical. But forgive me, but about those things, of course, we're going to talk, what I illustrate in a lot of other films. So I presume that all of you are pretty busy. So it's a lot of information. And what if you don't have much time? Yeah, because, okay, we're busy, we have our patients, we have our clinic, and of course you have your private time, you have your family, perhaps you have your children. So how can you incorporate everything? This is, of course, a challenge. And I would like to help you with this challenge. Yeah. I promised you at the beginning of the webinar that I would give you some information about our newest ultimate online toolbox. I started creating online courses already before COVID times, so already some years ago. But everything evolves, and thanks to the feedback of you and so many other colleagues, I'm able to constantly update and constantly improve my online toolbox. And if it's okay for you, I'm going to show you a little film. I'm going to show you a film which takes exactly 5 minutes. So I'm going to ask 5 minutes of your time. And then you're going to see what I'm talking about. What exactly is the online toolbox? So let's hope that technology works. Imagine you could have unlimited access whenever you want, wherever you want, to the complete course content of 10 live course days in orthopedic medicine. Well, this is the ultimate toolbox, the most complete online masterclass in orthopedic medicine. And let me show you what you can find in this toolbox. Well, we have a series of lessons. We start with the basics in clinical reasoning, where I offer you 9 different lessons, and then we divide it item per item or region per region, so shoulder, elbow, wrist, hand, and so on. For instance, in the lumbar spine, I present you 17 different lessons on history, clinical examination, treatment strategy, all you need to know for more success in your daily practice. Then we have a nice chapter where I illustrate all the palpation techniques, the friction massage techniques, the manipulation techniques, the injection techniques in all the different joints. And super interesting is the inspirational section. At present time we have about 14 lessons there, but we constantly update this. Here you have an overview of all the live webinars I gave, plus some extra inspirational PowerPoint podcasts. Of course, there are also a series of clinical reasoning exercises where I guide you to get your certificate. I also explain how you can use your assessment forms, and super important, all the course handouts, real handouts, assessment forms, and so on and so on. You just can download them over there in PDF. And of course, there's going to be a link to your certification test, and there's also a link to the personal consulting. So the question is, how does it look like? Well, I just log in to my account, and then I can show you in detail how it looks in reality. Okay, so I go to the ultimate toolbox, and for instance, let's click over here. Let's go to the shoulder. Okay. Can we define the impingement? Well, okay, I click over there and automatically the lesson is going to start. And of course you can also make your screen a little bit bigger, and you also have access on a specific app. There's also a link to the specific handout and the specific text which goes together with that particular course part. Let's go to the lumbar spine, for instance. Okay, which lesson do you want? The lesson about the predisposing factors? Voila! And there is the lesson, and you can just watch it whenever you want. Oh, and by the way, also super important, the course handouts. You just click on the course handout. For instance, this course handout has 123 pages. You just click on it and you click on the link, and automatically here is the complete course handout in PDF, which you just can download on your computer. It's a real handout. As you can see, it's not just a summary of slides. Okay. You would like to have your, let's say, the assessment form of the thoracic spine. Well, you just click on the assessment form, you click on the link, and there is the assessment form, and you can immediately download that on your computer. So in other words, it is super practical, super valuable, and the beauty of the story is you can also view all those lessons through the special Huddle app. So what about support in the online masterclass? Well, that's very easy. Whenever you have a question or a problem, you just click on community, and for instance you have a clinical question about a patient, you click over here, you just fill in your question, you send it, and automatically within the same day, maximum the next day, I'm going to help you. Okay. Voila. We are back. I don't know if you noticed, but on this online toolbox, there's also a free part, the 7 lessons discovery course. You just go to orthopaedicmedicine.eu and you can make an account over there, and okay, you can have a look at the free lessons. As you also heard, the complete online toolbox, you just have it within reach of your fingers. It's on a special app. So on your smartphone, whenever you want it, you're busy with the patient. How do I have to do the palpation again of supraspinatus? Just hop, and within 1 minute, you have the information you need. Okay. So what is actually the value of this toolbox? Well, to be honest, this is the complete content of 10 course days, 10 live course days. When I go to other countries and I teach 10 full days, well, all the content of those 10 full days is in the ultimate toolbox. So that's, that's quite a lot, okay? In the meantime, there are many colleagues who already work with the toolbox, and of course I ask for their impressions, and I ask them to help me to improve everything. And as you can see on the screen, there are quite a lot of very inspiring and very positive comments. If you would like to look at some comments on our YouTube channel, where there are many people who are going to tell you something about our courses, there are some even more extensive films of people who did the Mastermind course and share their experiences with you and me. So my question to you now, before I give you, because I didn't forget it, before I give you the assessment form, if you are interested in orthopedic medicine, and of course you are interested because you're here live with me, and if you feel, okay, I would like to improve, I would like to implement more of those things in my daily practice, wouldn't it be a pity not to have access to this toolbox? If you don't have access to this toolbox, what am I going to miss? Huh? I give you today, and it's just today, and Chinmoy says, I'm interested. Well, I'm very happy that you are interested. Well, I'm going to even make you more interested, I hope, together with many other people. Today, you can have 1 year of unlimited access to the toolbox instead of 90 days. And people ask me, yeah, okay, I pay with credit card. I have 1 year access, but then after 1 year, my credit card is going to be recharged again. No. Your credit card is not going to be recharged. Yeah, you have 1 year access, and after 1 year, automatically your license ends and your credit card is not recharged. So don't worry about that. And Chinmoy says, I want some more information about courses in India. Well, no problem. Just surf to our website, cyriax.eu. Go to the section worldwide, and there you can find the courses about India. I give you 1 year updates plus all the webinar recordings which I gave in the past and which I'm going to give this year. You have the access through the Huddle app, so you don't have any advertisement interruptions. Yeah. Fantastic. That's also nice, because when you go to YouTube channels, yeah, once in a while you have to take into account the advertisement, but not on the online toolbox. So you just look for the Huddle app. If you go for the free discovery course, I also explain you there how you can download the Huddle app. Yeah? And then, as I told you, everything within reach of your fingers. And I give you more than 500 pages of handouts. Yeah. And I don't know if you know the feeling, but if you follow courses, whatever, yeah. A few months ago, I followed also another interesting course on the shoulder. But in most of the courses, you get a copy from the slide. That's not a handout. I make sure you have real handouts. That's handout number 1. All you need to know, that's about the most common lesions in orthopedic medicine in the extremities. Handout number 2, everything about the lumbar spine. Number 3, everything about the cervical spine. Number 4, everything about advanced stuff in the upper extremity. And number 5, lower extremity. So actually, I'm talking about, I give you more than 500 pages of super handouts, plus all the assessment forms. And on top of that, I want to guide you in your study process, because nobody said orthopedic medicine is easy. Yeah, orthopedic medicine is not easy. It's a learning process, and that's why I want to help you with this learning process. So when you are in your study process, we make an appointment, and I give you 1 hour personal face-to-face consulting, Skype, WhatsApp, whatever. The question comes in, from where do I get these handouts? On the online toolbox. As you saw in the little film earlier, all those handouts are downloadable from the online toolbox. Everything. As I told you, the complete content of 10 live course days. So that's pretty amazing. And the last bonus, if this year, next year, whatever, if you would be one of my Mastermind guests, the special training program I organize over here in Belgium, and when you sign in for the online masterclass, then you get a 100% refund of your purchase. And I get a question from somebody, from a colleague who already is in the toolbox. And the question is there a way to prolong 1 year instead of 180 days I have now? Yes, don't worry. Just send me an email. You have my email address, info@cyriax.eu, and I'm going to make also a very special offer for you so that you can have 1 year access. No problem. Okay? And then, yeah, the question already came in, huh? Money, money, money. You already know what the value is. I put a price on it of 915.95 euro. Today, only for webinar participants. Only for webinar participants, you pay only 377. But I also promised, and I have to keep my promises. For those of you who are live here, fantastic that you joined until the end, because now is the moment that I can reward you. If you look at the right side of your screen, you're going to see that an offer appears. An offer only for those of you who are here live. I want to reward you because you were here live. This 377 euro for all the registrants, you have to hurry. This offer is valid until 21 February midnight. So because not everybody can be here live, so I want to give the opportunity to the colleagues who watch this webinar in a replay version, so you still have a few days. But for those of you who are joining live, you see on the right side what is happening. Yeah. Normally, you go to cyriax.eu/yes, and you use your discount code YES to get your special price. You who are here live, you see on the screen that you use another discount code. You use the code FIRST-YES, because you are first. And then you see what happens. Then you see there is a very special exclusive offer for you, but it's only valid 1 hour from now. You see, the clock is ticking. And why do I do that? Because I strongly believe in opportunities. The train comes along and you decide, do I jump or don't I jump? This is an opportunity. If you feel that, okay, I want to improve, I want to grow in orthopedic medicine, I want to become a better therapist, I want to have more pleasure in my profession, well, the toolbox is the thing you need. Perhaps you can ask yourself the question, what am I going to miss when I don't go for the offer? And I know. I remember 2016, I was following a very interesting seminar on personal development and relation with patients and so on. And they offered quite an intensive course, but I had to, believe it or not, I have to invest for this course. It was approximately $9,000. $9,000. Oh. For this online toolbox, we talk about other numbers, as you saw. But $9,000. I was afraid, but I felt I need it. I want to evolve. I want to grow. I want to go further. I said, no, my professional development is more important. I go for it. That was 2016. And today, I'm still very happy that I did it. So, in other words, I gave you a lot of reasons not to postpone. There's somebody says on the order form it's still showing 995 instead of 295. Yes, and I'm going to tell you why, because probably you forgot to do this. You go to the order form, but first you have to click the upgrade so that you have certainly 1 year of access. This is important. Click the upgrade first. And then you fill in your code for the live participants, or the first yes code. You click on the white arrow, and then you're going to see that the price is changing. If you go to cyriax.eu/yes, I also put a little film on it where I explain again how you can do that. But don't forget to click this box, yeah, and then it's going to work. I tested it before we were live, so it functions. Okay, great. So before I forget it, I promised you the assessment form. So if you look on the right side of your screen, the assessment form of the shoulder should be appearing so that you can also download it. It's in PDF. And don't forget your shoulder checklist, yeah, your homework for today or tomorrow. So if you have any further questions, feel free to ask your questions. I'm still here for a few minutes, so I'm watching the chat. So if you have any more specific questions on today's topic or on this online toolbox, just let me know. Okay. There's always a little delay before I receive your messages. After all, we're working in internet, so we have to depend on the speed of our internet service. Well, if there are no more questions for the time being, then I would like to thank you very, very much for joining me here in this webinar. I hope you enjoyed it. I hope it was useful, and I hope you can take some things and put it into practice. And of course, I'm always at your disposal. You know where you can find me. Just send me an email or go to the website and go through the contact form. I'm always there to further help you and inspire you. And keep in mind, you have 53 minutes left to enjoy your first Yes special code. So I hope many of you are going to jump on the train. Believe me, you're not going to regret your decision. Okay, so thank you very much. Thank you very much for the very nice positive comment I see here in the chat. Enjoy the rest of your day, relax, and tomorrow you take your shoulder checklist and then think back to this webinar, and then you're going to analyze, okay, which are the elements where you can further improve. Okay, so enjoy your day. I wish you all the best, and remember, check your mailbox. You're going to get some more emails from me. All the best. Enjoy your day. Bye-bye.